anatomy, soft tissue, angulations of his teeth, and it really allows us to treatment plan this case completely prior to ever sitting the patient in the operatory. So all the hard work in planning the implant diameters, lengths, sizes, as well as the abutments and the restorative protocol was done preoperatively, allowing us really to take this to the mouth, knowing without even raising a flap, without even starting the surgery, what the bone will look like and what kind of issues we're going to be involved with. This is really completely different than two-dimensional radiography, which was historically what we had in dentistry. We're going to be placing 2 implants, and the 2 implants are going to be placed in the area of congenitally missing lateral incisors. And this is his current stent that he has in place. This is his orthodontic retainer, if you wish, with 2 replacement teeth for his lateral incisors. We're going to be placing the implants basically to coordinate with the future tooth replacement. So this leads to the design of the restorative replacement of his teeth. On the other hand, we took an opportunity to cut a section of a surgical guide, and these guides were made off of the CAT scan to coordinate with the replacement of those 2 lateral incisors. I split it at the midline to give you an idea of what that would look like when placed in the mouth. This is what we have. Chin down a little bit. What we have right now is a very, very accurate placement tool for us then to guide our surgical delivery of our drills according to the size and shape and diameter of the future implant. So if we take a look at one of the larger ones, and we'll go ahead and go to a larger piece, we go up from 2 millimeter drill. This would be more like a 3 millimeter. We can go ahead and see that we can only angle in the position that was given to us by the preoperative diagnosis. This leads us to the appropriate angulation of the implant placed along certain guides and gives us so much more information than simply placing it through a surgical stent. So we've had the opportunity of doing that, and certainly that gives us the information we need, and we'll then coordinate that according to where we're going to place the future implants. All of this has been guided through 3D technology utilizing iCat and Simplant software. Due to the topography of this area, we had some concavities that we saw on the 3D images. They're, according to the areas, normally what you have in these areas is a little bit of deficiency in the bone due to the fact that the permanent teeth never formed. These concavities are down in the middle of the alveolar process. So we're going to try to place our implants slightly to the lingual with an appropriate angulation. We talked about this preoperatively, what kind of abutment that Dr. Garber is going to need. We think we can manage with a straight, not angulated abutment, placing the implant towards the palatal wall, and then filling this bony area, the concavity, internally, if we perforate, with bone grafting particles. We'll use autogenous bone, autogenous mixed in the drill through a suction. We'll actually save that bone, but we'll also utilize, if necessary, allograftic, demineralized freeze-dried bone, or demineralized mineralized bone from Zimmer called Puros, and we'll utilize and mix that with the autogenous bone if in fact we need it. We're going to try to build out some of this deficiency through the utilization of that bone, and we think we have enough tissue here that if any further aesthetic changes need to be made, they can be made at second stage. What we're going to go ahead and do is we're going to proceed with the placement of the implants based upon the CAT scan. We're going to utilize tapered screw vent implants from Zimmer for the lateral incisor replacement, and we're going to go to about 16 millimeters in length. We have available bone for that, which will give us good immediate stabilization, and we're going to need a little bit of depth, and we're going to use just as a guide for the placement of the restoration. I want to place it right in this angulation, so I'm just going to start the process of drilling the initial access based upon our CT scan, which gave us all the information. We're going to try to make sure we have our location of where the implant's going to be placed. You feel a lot of vibration out. So we're going to go ahead and drill right through this hole as an original purchase point for our implants. That's it. Into the section there. And then again on this side. Section. We're just suctioning, harvesting some of the bone from the original trap. Okay. And we're going to go ahead and evaluate those purchase points. You can suction in both spots. What we're going to do as well is I'm going to go ahead and open up the original access points to the location of the implants. And this is where the implants are going to be placed. We're going to go ahead and just open up these holes. Alan, go right there? Okay. Alan, you feel anything? Okay, good.
Open.
Just suctioning up the bone. It's coming out of the site. Clean that up a little bit. I'm just going to go make sure I have room subgingivally, and we're going to try to do this as a one-stage procedure. Okay. You have some more anesthetic?
Okay.
The length we need to have 3 millimeters subgingival, so we don't have any problems with the restorative. And that's why I need to put an extension. What you're seeing now is the extension, so I can get the proper length. Section. You can see again all the bone that Laurie's suctioning up. We're going to use again once we're done with the drilling procedure. And then again on this side. You okay there? You feeling a little bit? Okay. Vibration? Or okay. This is all the patient's own bone. So we're going to keep it all in one suction. Laurie's not suctioning anything but the bone. Good. Now we're going to change drills, go to the next size. the 2.8. This will be the last drill for this particular implant that we're using. So there's only two sets of drills, the 2.3 and the 2.8, and we'll go to the implant body.